This program is brought to you by Emory University.
Well, good morning. I think today we're in for a real treat. Les Leighton is going to talk to us about the decline in coronary artery disease in 1968. Les and I go back a ways. He and I first came in contact when we were both practicing medicine down at what was then Crawford Long Hospital, now Midtown Hospital, and Les was a gastroenterologist and I tried to do cardiology. Les's background is one of distinction. He got a degree undergraduate degree from University of Virginia, then went to Hopkins for his medical degree, and then went to the Brigham to do his then went to Bellevue to do his residency, an intern, and then went to Brigham to do both a clinical fellowship in gastroenterology and a scientific research fellowship in gastroenterology. A few other things of distinction on him, and some of these things that he is an Eccles Scholar at the University of Virginia. One you can tell me about was that you were a lone resident member of the Lawn Chowder and Marching Society at the University of Virginia. So I'm sure that's a thing of distinction, but I can't add to it. And then you've been in several who's and got honors at University of Virginia and been multiple times a top doctor here in Atlanta. I think that the other thing that has happened with Les is that with all these degrees and honors he's had in medicine, he's then deviated and went to Georgia Tech and got a Master's of Science in the History and Sociology of Technology and Science. And then went from there to Emory, where he's got a Master's of Arts, and now he's doing a PhD program in the history of medicine at Emory. So he brings to us both a combination of his medical knowledge and his knowledge of history as he presents this subject. We look forward to hearing from you, Les.
Thank you so much. I appreciate it very much. Thanks so much for that kind introduction. So what is a gastroenterologist talking to a group of distinguished cardiologists? Let me see if how does this work? How do I advance this?
Just use the arrows.
Oh, the arrow, okay. Yeah, perfect. So first let me make some disclosures. I have no commercial connections or so. I've got support from the Leighton Graduate School to do my PhD, and I got support from the Graduate Institute of the Liberal Arts to do the research I've done, but like I said, I have no conflicts of interest. How does somebody who practices gastroenterology for 20 years end up coming to study cardiology? I think I always wanted to be a cardiologist, but I was in a group of medical students that was so smart, I figured I couldn't be a cardiologist, I had to be a gastroenterologist, so that's what I became. But in later years, I came under the influence and friendship of Mark Silverman, who was not only a good friend and colleague when I practiced at Piedmont Hospital, he's also a patient of mine and a friend, and he got me interested in the history of medicine, and he also got me interested in the history of cardiology. And so when I came over to Emory, one of the propositions that was made by the group that I work with in the Institute of Liberal Arts was that I study this question of why coronary artery disease declined in the late 1960s. Nobody's ever been able to figure it out. So that's my dissertation topic and also my current interest in the history of medicine. Just give you a little bit of a historical perspective on coronary artery disease. You know, if we all think that it's been a disease that's been around for a long time, it's actually a fairly recent disease. Probably was known about in ancient Rome and Greece, but really it's a 20th century disease. There is an early description of angina pectoris to the 18th century. I'm going to show you that. But everything we really know about this disease started within the last 100 years or so. And even though the mortality has been declining since the late 1960s, it's still the leading cause of mortality in the Western world. William HEBERDEN is well known to all medical students and physicians, not because of what he did for cardiology, although that's really what we're going to talk about today, but everybody's heard of the HEBERDEN node of osteoarthritis, which is the inflammatory component in the distal phalangeal joint. But HEBERDEN was really a remarkable individual in terms of his description of disease in general. And in the 18th century, in 1768, he actually described angina pectoris, and then he wrote about it. And I'm just going to go over that description a little bit because it's of historical importance. HEBERDEN wrote, "There is a disorder of the breast marked with strong and peculiar symptoms considerable for the kind of danger belonging to it and not extremely rare. The seat of it and sense of strangling anxiety with which it is attended may make it not improperly be called angina pectoris. They who are afflicted with it are seized while they are walking, more especially if it is uphill and soon after eating, with a painful and most disagreeable sensation of the breasts, which seems as if it would extinguish life if it were to increase or continue, but the moment they stand still, all of this uneasiness vanishes." Just read a little bit more. "The pain is sometimes situated in the upper part, sometimes in the middle, sometimes at the bottom of the os sterni, and often more inclined to the left than to the right. It likewise very frequently extends from the breast to the middle of the left arm. The pulse is at least sometimes not disturbed by this pain. Males are more liable to this disease, especially such as have passed the age of 50. And this last paragraph is real important because I think what it did was it actually separated angina pectoris from coronary artery disease for a long time. I'll read that to you. "The angina pectoris, as far as I have been able to investigate, belongs to the class of spasmodic, not inflammatory complaints. On opening the body of one who died suddenly of this disease, a very skillful anatomist could discover no fault in the heart, in the valves, in the arteries, or neighboring veins, excepting some small rudiments of ossification in the aorta." So for a long time, angina pectoris was considered to be a very separate disease from coronary artery disease. It was considered a disease of the chest, but nobody really associated with coronary arteries, as hard as that is to believe. OSLER, who's considered the father of medicine, and certainly somebody you learn about when you go to Hopkins, talked a lot about angina pectoris. In his 1902 book, and I point this out to give you a sense of what this disease was like at the turn of the 20th century, in his Principles and Practice of Medicine, 5th edition, published in 1902, Osler writes extensively on angina pectoris. He writes in the book, "It's a disease characterized by paroxysmal attacks of pain, usually pectoral, associated with changes in the vascular walls, organic or functional. It is a rare disease in hospital. A case a year is about the average, even in the large metropolitan hospitals." And then he says death may occur in the first attack or at the end of a series of attacks. The interesting thing about this book in Osler in 1902 is he has lots to say about angina pectoris, but almost nothing to say about coronary artery disease. In fact, it's only mentioned 3 times in his textbook. And what he says is that complete obstruction of one coronary artery, if produced suddenly, is usually fatal. And I show this to you because I want to give you a sense of what coronary artery disease was thought of at the turn of the 20th century. Things changed, though. In 1903, this was what I call a game changer. It was the invention of the electrocardiogram. Wilhelm Einthoven, in 1903, invented the first practical electrocardiogram, for which he received the Nobel Prize in 1924, and it had a huge impact on the diagnosis of coronary artery disease. Now, when we say practical electrocardiogram, this is what it looked like. Hardly practical. You have a man sitting with both hands in saline and one foot in saline, but they were able to get tracings and tell something about the coronary, about the heart in general, and then about the heart. This is really the man that changed everything, and James HERRICK, who started out life actually as a public school teacher. He then went to a medical school in Chicago, and he was an internist. He wasn't a cardiologist, although I'm not sure how much cardiology was developed at that time in terms of professionalization. But he started out, he was an internist, and the first thing he described was what was called HYPERTENSION syndrome, which is one of the first descriptions of sickle cell disease. But in 1912, he published his landmark article on myocardial infarction. And when he published it, and what he did was he told the world that myocardial infarction was not a uniformly fatal disease. Up until that time, myocardial infarction was considered to be a uniformly fatal disease. And here's what he wrote in 1912. He said, "One may conclude from a consideration of the clinical histories of numerous cases in which there has been autopsy control from animal experiments and from anatomic study that there is no inherent reason why the stoppage of a large branch of the coronary artery or even of a main trunk must of necessity cause sudden death. Rather may it be concluded that while sudden death often does occur, yet at times it is postponed for several hours, several days, and you can live after you have a myocardial infarction. When he told this to the American Association of Physicians in 1912, they literally laughed at him. They thought, they ridiculed him and said that this was not possible. So he came back in 1918 and gave another talk to the same association, but he brought with him EKG evidence for myocardial infarction, and then they believed him. So in 1918 was really when this idea of chronic coronary artery disease began. I show you this early mortality statistics graph because I want to show you that if you look, the numbers start in 1927. Before 1918, the disease was considered uniformly fatal, so there are no mortality statistics. This is a graph that I got from Henry Blackburn, who is a cardiac epidemiologist in Minnesota, and has helped me with my study. And it shows circulatory disease in Norway, and you can see that the age-corrected and crude mortality rates go up. They decline during World War II, and then they rise again. I'm going to show you this chart, which is a better picture of, or a better graph of the mortality of coronary artery disease. And you can, this is in males 45 to 64 years of age, and you can see that the mortality statistics again begin around the 1920s. They rise, they start to plateau, and then by the late 1960s they decline. And this is for both age groups. I'm going to show you one more chart because when these statistics came out, when they noticed the decline in coronary artery disease in 1968, they said, well, it's not real. It's due to changes in classification of disease. And right now, and what happened over this period of time from 1950, and it's illustrated in this article in this graph, from 1950 to 1976, there was a change in what we call the ICD classification of disease. Right now, we're in the 10th classification. We're supposed to be going to the 11th classification in 2017. But during this period, we changed from the 6th to the 7th to the 8th ICD classification. So initially, people said, well, this decline is not real. It's due to the way we changed the classification of disease. But this article and this graph corrects for that change in classification of disease, and you still see a decline in the late 1960s. Okay, so they recognized the decline about 7-8 years after it happened. The statistics started to show that the mortality of coronary artery disease was going down. So in 1978, the NIH, through what used to be called the Heart Institute, now it's the National Heart, Lung, and Blood Institute, decides to hold a conference in Bethesda, and it's chaired by Sidney Blumenthal, and it expressed a desire to unravel the mystery of why the mortality statistics of coronary artery disease declined beginning in the late 1960s. And what they did was they assembled a cohort of 84 physicians, clinicians, surgeons, sociologists, economists, epidemiologists, and they convened in Bethesda, Maryland to try to sort this question out. Robert Levy was then the director of the National Heart, Lung, and Blood Institute, and he introduced the conference. And what he said was, since 1968, the decline in coronary heart disease death rates has occurred in both men and women, has occurred in every age group, and has occurred in our minority and majority populations. Any explanations which are put forth to explain the decline must be cognizant of the fact that the decline has been seen in our entire population. So it wasn't just white males or white females or certain groups. The decline was ubiquitous. So the objectives of this 1978 conference was to bring together a group of experts and to estimate the possible quantitative effect of the various identified potential factors on the decline in mortality. And the third goal was to suggest possible studies that might add additional information and to suggest new strategies for future monitoring of mortality trends. And the end result was to produce a document that actually could be used by the community and also for developing future plans. The conclusions of the conference were as follows. The decrease in coronary heart mortality is real and not a result of artifacts or changes in death certificate coding. Both primary prevention through changes in risk factors and fundamental and clinical research improving medical care probably have contributed to, but do not really explain, the decline. Many other causes of death declining as well suggest that a more general positive health force was operating in the U.S. We'll talk about that in a second. And a precise quantification of causes requires further studies be done. Here's the question that I've asked in my work and my dissertation. Is it treatment and care that led to the dramatic decline in coronary artery disease mortality in 1968? Or is it primary prevention and risk factor reduction that led to the dramatic decline in mortality in 1968? David Jones at Harvard and Jeremy Green at Johns Hopkins have shown good data to substantiate the effect of both beginning in 1974. But from 1968 to 1974, the data and evidence for a decline remain unclear and the subject of this project. When Jerry Stamler, who many of you I'm sure have heard of, who's probably the most authoritative figure on atherosclerosis, still alive today, and actually I had an opportunity to talk to him, which I'll get to in a minute. But when he was asked, can you identify factors causing the coronary mortality decline and measure their contribution, he said back in 1978 in an article in Circulation, when such multiple social medical trends evolve over the years, it is virtually impossible to make a definitive scientific assessment as to the role of each of them singly and of all of them together. So I've had my work cut out for me. Here is the proceedings of the Conference on the Decline in Coronary Artery Disease Mortality. It's a NIH government publication. And in it, Dick Havlick, who was then at the Heart Institute, and Manning Feinberg, wrote the following. They said if the total number of heart attacks is decreasing or the severity of clinical disease is lessening over this period, this would favor risk factor reduction as the possible cause of the decline. But if the total coronary heart disease incidence is unchanged, it would support the conclusion that fundamental and clinical research leading to modern medical treatment, improvements in treatment, would explain the decline. So I put together a little chart for you. So if you see, if mortality is decreasing, the incidence is decreasing, the primary reason is prevention. You have less people having disease, so the mortality is going down. But if mortality is decreasing and the incidence is staying the same, then it's probably the primary reason is treatment and care. So if you go to Framingham, and I won't go through this whole chart, but this is from the Framingham study from 1950 to 1970, and it shows that the incidence in both women and men did not change over that period of time for coronary artery disease mortality. So right now, from that information, it favors the idea that treatment was the reason why the mortality declined. So here's the methodology I used. I wanted to try to substantiate this finding. Statistics and epidemiological data, unfortunately, don't give you a complete story on this. Randomized controlled trials are non-existent. So I turned to a study of history to try and figure this out. And archival research is very valuable, and that's part of my study. And then I wanted first-hand knowledge from people who were alive at the time to see if they could help me figure out this question. So I took three approaches. I reviewed the statistical data for the National Center for Health Statistics. I did archival research into standards of care. And one of the things I used was I reviewed old textbooks like Friedberg's textbook and Wood's textbook and Sam Levine's textbooks, and also old articles, and I'll show you that in this talk. And then I did oral histories of the experts, but particularly those that were alive and involved at the time of the decline. I talked to clinicians, epidemiologists, even surgeons, researchers, and other observers. The oral histories that I did, I assembled a group of experts, somewhat like the group that was assembled in 1978. I talked to 18 clinicians. Some of them were academics, some were in private practice, 3 epidemiologists, 1 preventive medicine individual. And 2 of the experts that I talked to in this project were Henry Blackburn and Jeremiah Stamler, who were at the '78 conference as well. My criterion for inclusion, you had to be over 80 years of age, with a few exceptions. You had to have an expertise in the treatment and care of patients with heart disease. You had to be recognized as either a local, state, or national expert on heart disease, and you had to be in good cognitive health. There were a number of people I wanted to talk to. Richard Ross was one of them, but their health wasn't that good, so I didn't get a chance to talk to them. But you'll see I talked to quite a few people, and these are the people I talked to. A number of people from Emory. I talked to Dick Conti at the University of Florida, Tom Ryan, who was former chief of cardiology at Boston University, Arthur Sasahara, who was at the VA hospital in Boston, Eugene Brownwald, Roman DeSanctis, William Roberts, who helped me quite a bit, Jack Hyland, who was chairman of cardiology at Baylor, Jerry Stamler, Henry Blackburn, and then I talked to Norman Kaplan, who I'll tell you a little bit about in just a second, Charlie Hatcher, Bob Copeland, and Bernard Lown. Well, the interviews, each subject was asked identical questions. The interviews went from anywhere from 40 to 90 minutes. You'd be amazed at how much people wanted to tell me about their lives and their backgrounds and their interest in cardiology. I then rated each interview from 1 to 5 on the probable reliability of the interview, and most of them were fairly reliable.
Do you see those scores?
I keep those in a vault. Anyway, each subject was questioned about risk factors: smoking, hypertension, diet, obesity, and cholesterol. And then each subject was questioned about treatment and care. Let's start with smoking. This is a real controversial risk factor in terms of its effect on the heart. And even the Framingham study didn't, it addressed smoking, but it never came to a real hard and fast conclusion about smoking. I just show you a graph of the consumption. This is from the Department of Agriculture. Shows the consumption of tobacco over time, cigarettes and the various other ones. And you can see the consumption heads straight up through the 60s, and it really doesn't decline until about the 70s or 80s. Here's a better graph that shows the same thing. And what you can see is rising consumption of cigarettes, and it starts to plateau out. Here's the Surgeon General's report in 1964, and then it flattens out. It really doesn't decline until the 70s and 80s. And what's interesting about smoking is when I first started this project, I went to see one of your colleagues in Rollins School of Public Health, and I asked him, why do you think coronary artery disease declined? And the first thing he said was because people stopped smoking. I'm going to show you that wasn't the case. These graphs show you that. And this is when I talk to people about tobacco, everybody agrees, and there's no debate about it, that tobacco has a profound, and cigarette smoking has a profound effect on the lungs in every way, and it's a permanent effect. But in terms of the impact of tobacco on coronary artery disease, there's a lot of disagreement. When I sat down and talked with Eugene Brownwald, he told me it acts quick. The coronary part is forgiven very fast. In a year, all is forgiven, meaning that in order for cigarette smoking to be a risk factor for coronary artery disease, you literally have to be smoking at the time you get your heart attack. If you stop smoking a year ago, according to Brownwald and the literature, the effect goes away. There's a very short latent period. When I talked to Dick Conti at the University of Florida, he told me, I can't think of one good reason why anyone should smoke, but whether it really does anything for ischemic heart disease or coronary artery disease, I'm not sure about that. The current evidence is that tobacco impacts coronary disease, but it's strictly epidemiological. And one of the most interesting things, and I'll share this with you because this is the fun part of doing this project, when I talked to these experts, most of these people that were coming around in the 1960s didn't get trained in cardiac catheterization during their training period. So they had to go up to the Cleveland Clinic and visit with Mason Sones for a couple of weeks to learn how to do coronary angiography. And when they went into, and I can tell you 4 or 5 people told me the same story. Mason Sones would do his cardiac casts, and you may know this history. By sitting there, he had gloves on and he had a hat on, but he didn't have a mask. And next to him was a towel, a sterile towel, and on the towel was a Kelly clamp with a cigarette in it. And every few minutes, his nurse would come with the Kelly clamp and put the cigarette up to his mouth, and he would puff away. And some of the people told me he'd even puff into the face of the person he was cathing. And unfortunately, he ended up dying in his 60s from lung cancer. So even in that period of time, people told me everybody was smoking. I think it was Jack Hyland told me he'd go to the American Heart Association meetings in the 60s, and he said he learned early that he had to sit in the front of the room to see the slides or the speaker, because if he sat in the back of the room, there was so much smoke in the room you couldn't see the screen or the speaker. So most of the people were telling me that individuals kept smoking during the 60s. There was no decline in smoking as a result of the Surgeon General, or none initially. And when I went back and looked at articles from the Department of Health and called the tobacco situation, you can actually see that the prevalence of smoking did not decline until later. How about in terms of hypertension? Most people told me that for the risk factor of hypertension, the general observation was that there were few medicines, fewer treated, and fewer controlled. The consensus was that there was little impact of the control of hypertension before 1968. I talked to Norman Kaplan, who's the author of a book called Clinical Hypertension. He's now writing his 12th edition. He's at the University of Texas in Southwestern in Dallas. And when I asked him, when we talked about it, he told me in 1972 only 12% of patients with hypertension were considered to be adequately controlled. If you look at what we've done in the ensuing years, it is now about 47%. And then he said, for the sake of being under some kind of treatment and thereby presumably lowering, we are now at like 80%. So about 80% are now on treatment, but only 47% now are controlled. Those numbers were way lower in the 50s and 60s. So I turned to him and I said, when you went to Dallas from the NIH in 1961, did people feel the need to treat hypertension? What he said to me was, no, I think there was a general apathy. Part of it was because we didn't have easy medications. Guanethidine was terrible. Aldamate was very popular. You know, methyl-dopa, but was always difficult to use. It caused a lot of side effects. So even though we began to see medications that would work by oral administration, it didn't seem to have a major impact. And it wasn't, and he told me it wasn't until like 1970s and early 80s when the drug companies got involved in these large hypertension control trials with their medicines that hypertension really came under control. So we've excluded tobacco as an important factor, hypertension. Now let's talk about cholesterol. I interviewed Jerry Stamler at his apartment in New York. He's between Chicago and New York, and he told me, this was about 2 years ago, he said, you better get up here because I'm 92 years old and I travel and who knows what's going to happen. So I talked to him at great length. He was incredible. And what he told me was that back in the 60s, we knew about cholesterol. There was a lot of information about cholesterol, but people were still very skeptical. And the literature bears this out. There was a great deal of skepticism about the role of cholesterol in coronary artery disease. The idea of cholesterol being important to coronaries was already fairly implanted in the 1960s through the work of the Russians, which did their studies in the early 1900s, and also Louis Katz in his lab in Chicago, but it was not translated into the clinical side. The final conviction, he told me, and elimination of all the skeptics didn't occur until the statins came in the 1980s. I took a look at Charles Friedberg's textbook. Charles Friedberg was the chairman of cardiology at Mount Sinai from 1957 to 72, and he died in a car accident actually in 1972. But his book, and Nanette Wenger was one of his students, and BRAUNWALD told me about this book. It was a single-authored textbook on heart disease, which BRAUNWALD told me no one would ever do now, and he couldn't understand how anybody did it then. But in this book, it talks about the treatment of coronary disease in terms of atherosclerosis. And what it says theoretically it would be desirable to direct treatment against the basic cause of coronary artery disease, namely atherosclerosis. But the efficacy of any measures with regard to the prevention or treatment of human coronary atherosclerosis is yet unproved. So that was in 1966. And then he makes this statement, from the viewpoint of clinical practice, there is no acceptable specific treatment of coronary atherosclerosis. Many of the recommended measures deserve and are undergoing further investigation. To me, this speaks to the fact that very little was done in terms of cholesterol back in the 60s. So now we're at the last part of this talk in terms of treatment and care. And I talked to all these experts about how treatment and care occurred in the 1960s, and they told me about the coronary care unit, defibrillation, ambulation, etc., etc. And here's a chart that from an article that was written by Elizabeth Nabel and Eugene Brownwald. It came out in the New England Journal about 2 years ago, and it shows the decline in coronary artery mortality with all the scientific accomplishments that occurred over the period. Coronary care unit coming in 1961, risk factors from Framingham defined in 1961, first beta blockers 1962, Favalaro, the first description of cabbage, in 1969. And you can see the decline occurring along these scientific accomplishments. Well, when I talked to Eugene Brownwald, it was an incredible talk. I hadn't met him when I had trained at the Brigham, but never had an opportunity to really engage with him, because he was such a luminary figure there. He's still very active today. He runs this TIMI study group with an office on Longwood Avenue, and I went to talk to him, and he talked to me for probably an hour, hour and a half, and he told me what he thought was the reason for the decline in coronary artery disease mortality. And I asked him that question, why do you think there was a decline in coronary artery disease mortality in 1968? And his answer was, and he's written about this extensively, he said, I think it was the CCU. The first paper was in 1961. The world was ready for the concept of the CCU, and it spread over the world like wildfire, especially in the United States. Here's a chart that shows you the growth of the CCU. 1960, there were no CCUs anywhere. And by 1972, there were 2,300 CCUs. And then Brownwald went on and told me about, made this statement. He said, another thing that really resonated in the United States with the CCU in the early 60s was the beginning of a feminist movement. With the CCU, nurses, primarily females, were empowered with new responsibilities and no longer had to wait on physicians, primarily male, to act. So he thought that was important, that we had empowered nurses to start taking care of patients with coronary disease, and he felt that was an important factor in the decline of mortality. I talked to Jack Hyland, who was the chief of cardiology at Baylor in Dallas. He told me in 1962 the care of coronary patients was literally boring. You couldn't do anything for it. Bed rest was essentially the only treatment of a heart attack. He said the CCU care required the patient to have an internist involved, but also a cardiologist. This was the start of, or the expansion of the work of cardiologists. It allowed for better interventions for patients who were seriously ill. And the CCU also, in addition to empowering nurses, it mandated standardized orders for all patients. So it created a new standard of care. He also told me the role of Medicare and Medicaid should not be considered. He said in 1965, Medicare and Medicare came into existence. And quote, he said, remember Medicare came in 1965, it changed my world because all of these people were now enfranchised and could come in and expect and pay for service. 1/3 of my practice, and I think it was not different from most internists, all of a sudden I had more work than I could do and I was getting paid for it. Finally, I talked to Bernie Lown in November, and I went to speak to him at his house in Newton, and Bernie's probably about 93 years old. Just an incredible figure. He had been at Harvard Public Health and the Brigham Hospital for years. He's also a Hopkins graduate, so we had a lot to talk about. He's known for the invention of the defibrillator. He's also known for having received the Nobel Peace Prize for his in the 1980s for his involvement with nuclear nonproliferation. He worked with Samuel Levine at the Brigham, and he was the one who opened the CCU at the Peterborough Brigham Hospital. And here's a picture of me and Dr. Lown. Anyway, what Lown told me was he believes that the mortality of disease in general was declining fairly broadly around the world. He says the chair had a big impact. I don't know if you know what the chair is, but in the early 1950s, Samuel Levine wrote an article in the American Heart Journal about what he called the chair. And this was getting people out of bed, sitting up on either the edge of the bed or sitting up in a chair. And it's a real interesting article, and he felt that it impacted mortality almost immediately. And it's not scientific, it's more anecdotal, but what he said was the mortality at the Brigham went down from about 15% for coronary patients, for heart attack patients, to 10% using this chair. And Lowndes said he felt that the chair, or this idea of sitting people up from bed rest, had a huge impact on mortality. And when I asked him, was it only at the Brigham, he said, no, it started to spread all over the place. And when I implied that it was the Levine chair, he said, no, it's the Lowndes chair. So I said, okay. Anyway, he said the coronary care unit may have been too early to impact mortality in a serious way by 1968, but eventually it had a huge impact. Prevention, he felt, probably played no role whatsoever in the early decline in mortality. Just want to make one mention of Thomas McEwen, who you may have heard of. McEwen was a physician and a medical historian back in wrote a lot back in the 1970s and 1980s about the decline in mortality in general. And it was his feeling, and what the McEwen thesis is, he attributes the modern rise in world population or the decline in mortality from the 1700s to today to broad economic and social changes having nothing to do with treatment or prevention. His idea was that disease mortality was declining anyway. And he shows this in TB. And here's a chart of the decline in mortality of tuberculosis. And you can see it's already starting to decline before even the tubercle bacillus is identified, and then even before there's effective treatment. So there appears to be a factor involved in the decline of all diseases, irregardless of treatment, prevention, or anything else. And that's the McEwen thesis. And some people agree with it, and a lot of people don't, but it seems to be a factor that we need to consider and something that I'm considered in my work. So the conclusions. The pre-1970 and post-1970 experiences in terms of mortality for coronary artery disease are very different. We know after 1974 that treatment and prevention had a combined effect on continuing to lower mortality. But notions of prevention were known prior to the 1970s, but probably played no significant role in reducing coronary artery disease mortality prior to 1968. Statistical and historical evidence exists for this claim. Then greater awareness, improvements in getting patients to care, treatment and care, including the coronary care unit, the chair, increasing professionalization, standardization, and access to medical care in terms of Medicare, Medicaid, and other factors probably influenced the decline in mortality more so than prevention. A new era had begun. The 1960s introduced many changes into the care of patients, particularly with heart disease. The combination of a fundamental change in the way medicine was practiced, the empowering of new professionals to respond to patients and administer care and treatment, and the introduction of new ways to pay for care no doubt contributed to improvements in morbidity and mortality of coronary artery disease. A new era in the care and treatment of patients have been ushered in. Thank you. We're not quite at the buzzer, so I have some time for questions if there's any questions.
Open it up for questions. A couple of comments I remember is that the thing I can remember early about coronary disease, and Bill Roberts got caught in this, is whether the thrombus was a cause of an infarct or was a subsequent consequence of an infarct. And Bill Roberts wrote an article saying that it was a consequence of the infarct, and this, of course, led for long discussion for a number of years. Another story was about Mason Soanes, and that somebody that was trained there came and set his own practice up, and he had the hemostat set over on the side, just like Mason Soanes did, and everybody coming off it into the cath lab and always asked what that was all about, and it was just because Soanes had it on his, excuse me, can I call you back? Thanks. Any comments or questions? Some of us go back to not quite this far, but can see changes. Spencer, you have any comments?
Well, that part about all the people you interviewed had to have a cognitive exam before you interviewed them. I'm not sure we all passed that. But one thing that I think I mentioned maybe to you when we talked about this was the difference in incidence of coronary disease and then the expression of it. I mean, when we say how many people have coronary disease, you know, we have to get to the point of having complications of vascular disease before you can ever get there. So it's always been a curious thing to me to think about, you know, and because we have no real background information about how much, if we did calcium screening on everybody in the population, which kind of is being done now a bit, but you'd find a lot of coronary disease that we call not coronary disease that has developed, and maybe prevention helps with that. And the smoking thing, I've always thought was, you know, a thing that produced thrombosis. I mean, mainly produced thrombosis. So that's the whole. So people smoke, probably got coronary disease. They smoke, they boom, or maybe they don't, but they have the event, and it's a quick thing. But it's fascinating to think about. The most fascinating thing to me to think about is you can't figure it out. I mean, it went down, but all these factors are in the socioeconomic thing. I mean, there was a huge rise in, you know, post-depression, post-World War II, and the middle class, and people, you know, became, you know, able to take care of themselves. And so the only one other thing I would say is that I know the Brigham and the BI people would never give credit for this, Bob, but Paul White, you know, did have something to do with getting people up and moving around too, from the general. Here's another cognitive competent guy.
In terms of Paul White, he wrote real early articles about the benefits of exercise, you know, and in fact, right around the Mass General, there's the Paul Dudley White bicycle paths. And he was a big advocate, and that's throughout the literature of increasing exercise, getting people mobilized early, and things like that. Go ahead, Paul.
Spencer and I were born before people learned how to turn on these devices. One case I'll mention that some of you know, Dr. Cobbs, the late Dr. Cobbs, had a person who developed symptoms with cigarette smoking, so he was taken to the laboratory, and the coronary was injected, and then the patient smoked in the lab, and the coronary became occluded. And so that speaks to what Spencer suggested about smoking and sudden closure of artery. I would go back to the person who thinks that disease in general, not just coronary disease, started to lessen at that time. And maybe it's a general reduction in chronic inflammation, less tuberculosis, better control of rheumatoid arthritis, less infections, better dental hygiene, and maybe that's very large. I am thinking again of René Dubois' book on Mirage of Health that pointed out that all this decline in infectious disease really antedated antibiotics, and it was due to less crowding and better sanitation and so on. I enjoyed that, Les.
No question
Thank
about
you.
it. That probably has an impacting factor in this whole discussion.
I've been reading Stephen Ambrose's wonderful book about Dwight Eisenhower, and it prompted me to look up and read a little bit about his heart attack. And it was in 1955. He was on vacation in Denver. He had been a 4-pack a day smoker. It's hard to see how somebody could smoke 4 packs a day, but he had actually cut down to 1 pack a day when he had his heart attack. And the article I read pointed out that at that time in 1955, the recommended treatment would be 6 months of bed rest. So he was in Denver. He went to Fitzsimmons Army hospital and was hospitalized for 7 weeks. And Paul Dudley White intervened and said, yes, he could fly back east. And he was apparently just sorely criticized for getting President Eisenhower out of bed after only 7 weeks. But I guess that was what his contribution, I think. And it really changed a little bit the way patients with myocardial infarctions were treated after that Eisenhower example.
Right, and Levine, and the thing about Levine, he wanted people to get out of bed because mainly because of failure. What he perceived was that these people were getting problems with failure, and they were lying in bed, and their legs were draining to their heart. So he said, if you could sit them up, and you get the fluids out in the periphery, and you don't have to worry about the heart. But Lowndes said it was much more than that. It was this whole idea of decreasing thrombophlebitis, all kinds of issues related to the heart. It was just better to get them out of bed. And if you want to read an interesting book, you should read Good Calories, Bad Calories by Gary Taubes. I don't know if you've heard of that, but that has a whole section about Eisenhower. And Eisenhower actually probably set this whole thing for cholesterol back about 10 years, because Eisenhower tried to be on a very strict low cholesterol diet. He wouldn't eat eggs, he wouldn't eat butter, and his cholesterol levels were still high. So, and it's called the Eisenhower paradox, that even though he was on the most strict diet he could be on, he still had high. In fact, they wouldn't even tell him his cholesterol levels after a while because he would get too upset about it. So his cholesterols ran in the 250s even on a strict diet. So it kind of set back this whole diet-heart hypothesis for a while.
One interesting story that Dr. Hurst told me, and probably some of you have heard it before, was that he took care of, Dr. Hurst took care of Lyndon Baines Johnson, who at the time was majority whip and a Democrat. And then Paul Dudley White, who was Dr. Hurst's mentor, took care of Eisenhower, who was a Republican and been president of the country. And so they followed up, and both of them had inferior infarcts. Lyndon Johnson's EKG over time resolved and returned back to normal. Eisenhower's didn't. And so they had a press conference one time, and of course, Lyndon Baines Johnson tried to use this politically. It says, my EKG is back to normal, I'm normal. And so that night, Dr. Hurst got a call, and Paul Dudley White always called him Willis rather than Willis, the German name. Says, Willis says, what's this about Johnson's EKG being normal? Is it normal? He said, yes, sir, it's normal. He says, well, Eisenhower's driving me crazy. He's kind of figured out how Lyndon Johnson got cured, and he didn't. So.
That was a great talk. Thanks so much. One thing that bothers me is about how we treat our death certificates and how do we sign death certificates. So, you know, we disguise what folks die from. For example, in this hospital, you know, we don't let them die in the CCU. We don't let them die in the operating room. And they go somewhere else, and Lord only knows how the intern or resident signs that death certificate. And then how we retrieve that data and make something out of it is confusing. So we don't teach our house officers to sign death certificates in a certain way. We probably don't know how to sign them ourselves.
Well, there's been a number of articles more recently written about death certificates over-reporting of coronary disease in hospitals, because everybody dies of, you know, acute, you know, whatever. I mean, it's always signed out as an acute MI or something, or acute this or that. And there is an over-reporting of coronary mortality in hospitals based on death certificates. But even that has declined over time. So in other words, it doesn't affect what I'm talking about, but you're right. And there have been 3 or 4 articles within the last few years about the over-reporting of heart disease on death certificates.
Where do you think that information comes from as far as the cause of death? Does it come from hospital coding, or does it come from death certificates, public health department, or in your mind, where does that come from?
I think it comes from death certificate. I think that you know, it's an acute. We report a lot of these as acute events as the result of something else. So the last defining event on the death. I haven't filled out a death certificate in a long time, but it's always some acute event that gets attributed to the heart as the final event when we don't know what else to write down, is my impression, but I might be wrong.
It's the default around the world. I mean, I do some adjudication for different studies, and you see this thing: person died suddenly, and cause of death, heart attack or something like that. There's no evidence in the history anywhere, but they were alive, they're dead, they must have had a heart attack.
In the old days, that was acute indigestion.
Well, I haven't seen acute indigestion on any of these.
You have to go back about 100 years.
Any other questions? Well, Les, we greatly appreciate it, both informative and entertaining. Wonderful. That was good.
The preceding program is copyrighted by Emory University.